Okay. All right. Okay. All righty, everyone. Good morning. Why don't we wait just another minute and then we'll get going. We believe it's already May. Oh. Okay, let's get going. All right, so this is a tracing of a teenager who comes to the emergency room with palpitations. And so why don't we see here what Dr. Abdul Karim believes is going on here.
Good morning.
Been feeling this for 2 hours, she tells us, or he tells us.
I see. So the heart rate is I would say maybe 200 or something.
Well, is it really 200?
It's close to 300, I guess, but
No.
let me see.
How many boxes are between them? So almost a little less than 2 full boxes, right?
Around 1.5, I guess.
Yeah. So it's probably closer to about 170, 180.
Okay.
That's important. So got to get the heart rate right is very important to start. Okay.
I see. Okay. And then I think looks like maybe atrial flutter.
Okay. Why are you saying that? Is it a regular or an irregular rhythm?
It looks like regular.
Okay. And do you think this is a narrow or a wide QRS tachycardia?
It's a narrow tachycardia.
Yeah, it's probably narrow. I mean, if this were a newborn, I would probably say it's wide, but for a teenager, this would be a narrow. And is the QRS axis a usual axis for a person who's otherwise well in 17 or 16 with palpitations?
The axis looks normal as well.
Okay, right. So the first thing I would say is you said that it's possibly flutter. So how common is atrial flutter in someone who, this person's never been seen by a cardiologist before? It's the first episode. So let's just say, for the sake of conversation, it's likely, right, that someone who has never seen medical care before does not have congenital heart disease, we would hope. So do people who are teenagers get atrial flutter in the teen years with any regularity?
I guess it will be not common to have that.
That's very, very uncommon.
Yeah.
In fact, I would hazard to say that no one on this call has seen either Dr. Love or I perform an atrial flutter ablation in somebody who has a structurally normal heart. Although it's quite common in adults, particularly older adults, to have atrial flutter. One of the more common things that they do is flutter ablations in adult EP world. In pediatrics, it's very unusual to see atrial flutter. Now, it could be flutter. This could be some kind of one-to-one atrial flutter. I don't think we really see any buried P waves anywhere. Do we see any P waves at all? obvious P waves?
I mean, mm, maybe in one of I see, for example, in V5, the
V5.
could be like somewhere
You
in the
referring to
middle.
something in here? You're saying maybe here.
Yeah, not like the one in the like the lowest, the one in the lowermost part of the screen,
Over
like the
here?
tracing.
Oh, on the bottom, I see. Okay. So you're
Maybe when
saying that maybe this thing is a P wave. Is that what you're saying?
no. If you go more to the middle, like more
Like
to the
this?
right,
Huh?
somewhere I feel like there could be like an inverted P in one of the waves in the middle, like
Maybe.
the one to the left. Yes, this one. Yeah. Like after the T, I feel could be an inverted
Uh-huh, I see. I
P.
see.
Um,
Maybe.
but I'm not sure. Like I cannot see that
Right. I
regularly
think it's
though.
pretty clear that the P waves are not easy to see, right?
Yeah.
That's fair. So if we just said we didn't have a tracing, and I just said to you, I have a patient who I think is having some form of SVT, and the
Mhm.
heart rate's about 180. What would, in your mind, would you think is the two most common diagnoses?
Um, so
For SVT.
I would say maybe re-entrant tachycardia if is
Right.
like ORT kind of.
Uh-huh. ORT would be the number one most common. That's absolutely correct. And what would be the second most common?
The second most common could be AVNRT.
Right, AVNRT. So ORT and AVNRT are like 97% of the tachycardia that we would see of the reentrant arrhythmias in kids would be one of those two. So then the question is, and so there's a very high likelihood, a 98% likelihood, that this is one of those two, because you have a narrow regular QRS tachycardia with in a child who is at the right age to have one of those two diagnoses. So question then is there any way, are there any clues or hints that this could be one or the other? So I'm going to turn now to Dr. Kalis and see if she has any thoughts on how we might be able to ferret out which of those two this might be. And by the way, we really don't know for sure, but we're just having a mental exercise here.
So one thing you could do is look at the RP interval.
Uh-huh. I like that very much. And what do we know about RP intervals and ORT versus AVNRT?
So I think with AV NRT, the RP interval is shorter than in ORT.
That's absolutely correct. Excellent. And do you remember what the sort of traditional line in the sand is that separates the one from the other?
I think it's 60.
It's actually 70.
70.
Close. That's pretty good. I think if you get within 10 milliseconds, we'll give you full credit. Right. So 70 milliseconds is traditionally the difference. Although one of my former fellows, Scott Seresnak over in Stanford, wrote a paper a couple of years ago in which he showed that in small kids, 50 actually, there were some patients with ORT whose RP interval was closer to 50. But generally speaking, 70 milliseconds is sort of the line in the sand. So, in this case, it's hard to say where the P wave is. I agree with Ali that maybe there's a P wave sort of on the T wave here, but without seeing the sinus tracing, it's hard to know what's what. So, Maya, what would you do at this point? So your patient is in the emergency room. They feel okay. They look fine. They have a reasonable blood pressure, good perfusion, but is clearly feeling palpitations, does not like that.
Okay. So I guess if we're hemodynamically stable, I guess I would call this like SVT stable. And I would start with trying to do vagal maneuvers.
Okay, so what vagal maneuvers would you recommend for this patient?
So this is a teenager, so we could initially try, sorry, we could initially try instructing her to bear down.
Right, so nice bearing down exercise. So how do you recommend that? What should we be telling patients when we say bear down? Should we just go to the toilet and have take a dump? What are we asking them to do exactly? We say bear down.
One way I've like seen it done that is like sometimes works is if you put like a hand on my patient's abdomen and ask them to like push your hand out.
That's a good one. I like that. So let's say it doesn't work. You do that for how long should the patient try that? In other words, like, okay, so you say, "All right, I want you to push against my hand." So your hand is on the patient's abdomen and they're pushing against it. How long should you hold that for?
I guess I would do like maybe about 10 seconds or so.
Yeah, 5 to 10 seconds, I think would be fine. Okay, so you do that and it does not stop. Is there any reason to try again? Or would you just say, well, I guess vagal maneuvers is ineffective in this patient?
I think you could try again.
Yeah, that's good. Yeah, normally I would recommend someone try 5 to 7 times.
Okay.
You always want to give it a couple of tries. All right, so that's one good vagal maneuver. Let's say this was a 3 or a 4-year-old. Any other ideas? Smaller,
Probably do ice to the face.
right? You could do ice to the face. That's common in babies. And one thing that's very important is you have to basically smother the patient for like 10, 15 seconds. You have to cover their mouth, their nose, their mid face, and their forehead. And it's kind of, if you're doing it right, it's sort of unpleasant, actually. You're doing something that goes against the grain of everything you're taught as a human being, which is you're trying to suffocate your child transiently for 10 to 15 seconds, maybe. Also, I've seen people literally take a big bucket of water and cold water and put their head in that. I've had more than one teenage family tell me they do that whenever their child has SVT. Another good vagal maneuver is to ask a patient, is to actually have them do like a handstand. Now, obviously, if someone is unstable, you would never ever do this, but I've seen a lot of parents of smaller children, let's say 2 to 5 years of age, who tell me that they hold their child upside down, being very careful, of course, not to drop their child, and that is actually a very potent vagal maneuver. What about carotid massage? That's sometimes pointed to, and every once in a rare while, you'll see some patient who or you'll get called to an emergency room and the ER doctor will tell you they tried carotid massage and it didn't work. Are you a big fan of that? Not a fan? Should we expect it to work? Is there any good reason to do it? Bad reason to do it? Not do
I would say I'm not a fan of that.
I would agree, but why? Why is that not a good thing?
Well, I think for one, you don't want to like compromise the blood supply if you're, massaging
Okay.
the
I mean, you'd
carotid.
have to be a really serious compressor to to compromise the blood supply. You mean to a person's brain, you're saying?
Yeah.
Yeah, I mean, you'd have to push with some serious force to do that. Also, hopefully, most patients have a circle of Willis. So if you transiently for a few seconds block flow in the carotid, hopefully you will not. And do you notice how when we do vascular access in the neck and we're checking to see which is the carotid and which is the IJ, you remember how do we know the difference between them when we push down on the probe?
Well, the IJ is compressible
And what about the
and
carotid?
the carotid not so much.
Right. So your risk of actually compromising flow to the brain is pretty low, right? Because you see that we push with some force with the ultrasound probe, but we can't usually compress the carotid. What are we actually pressing on when we're doing that? Since we're not actually truly deforming the carotid, what is a carotid massage theoretically compressing? So the answer is that there are like these little baroreceptors
Yeah.
on the outside of the carotid that control blood pressure or that are part of the mediation of blood pressure. And theoretically, if one were to mash on that with a lot of aggression, you could reset baroreceptors or cause problems with blood pressure afterwards. And so as a general rule, we do not favor carotid massage in anybody, and it's pretty much fallen out of favor because of concerns about that. So really, we should never be doing that. Okay. You could try all the other things that we discussed. Sometimes in small infants, people will put a rectal thermometer in their rectum for like a little rectal stimulation as a vagal maneuver. I've seen that work once or twice. So those are some of the things that we do. Okay, so you've tried all of that, Maya, and unfortunately, the patient remains in tachycardia. So what would your next step be?
Then
Patient
the
is
next,
fine, though, feels okay, still feels the palpitations, not happy about it, but looks okay.
then the next step would be adenosine.
Exactly. You would give adenosine. And how much adenosine would you give per kilo?
I'd start at 0.1 per kilo,
Right.
followed
And
by a flush.
right, with a big flush behind it.
Mhm.
So thankfully, we have that tracing here. And adenosine has been given. And those nice arrows at the top and the bottom demonstrate when we are seeing effective adenosine. So what are we seeing here?
Okay, so we gave adenosine, and then it looks like, so the first beat after, there's a pause, and then the first beat is wide.
Yep.
I don't know
I
if this
agree.
is like a ventricular, like if there's a, there's like transient AV block. So I don't know if this is just like a ventricular escape beat.
Mm-hmm.
And then we go back into a narrow rhythm. There's a lot of artifact on the baseline, so it's a little hard to tell, but not seeing
We have
obvious P waves.
We have a 12 lead that was obtained literally seconds after that, which I will show you. This is the 12 lead after the
Okay.
same patient. So
Um,
what would you say the rhythm is now?
so I mean the P waves look very much like the T waves, but I think it is a sinus rhythm.
Yep. Yep. So we're back in sinus rhythm. And what's the rate?
See, our rate is about like maybe like 120 or so.
Yep, I agree. So so when we look at this rhythm in sinus, it's interesting that there is this little inflection after the QRS that's sort of naturally there. Initially, I was wondering if perhaps that was a retrograde P wave when we were in this rhythm, right? You see how we have this little inflection here, but actually it's there in sinus rhythm also. And if we look at the T waves in sinus, and then we look at the T waves in tachycardia, here they're kind of flat and inverted, but here it looks pretty similar, right? To the sinus one. This one is a little taller, but similar axis at least. So a couple of points. So first of all, you correctly noted that there is a wide QRS beat after adenosine. And one thing that you should note is that it is very common for there to be either PVCs or VT after someone receives adenosine, at least transiently. It's very common that you see sometimes even a little run of 2 to 4 beats of VT. I'm not actually sure why we see this in people who have received adenosine. But this is not uncommon. The other thing that's interesting or important is at this point, the patient has adenosine on board, albeit it's rapidly being metabolized. But we see here that the PR interval on this beat is low. And what we do see, and what's very important, is we do not see pre-excitation, right? So at a time that you give adenosine, the first beats that come back that are conducting often are pre-excited beats, because remember that adenosine is that accessory pathways rather are usually adenosine insensitive, whereas AV nodes are adenosine sensitive. So one of the nice things about running the tracing when you've given adenosine is that if a patient is intermittently pre-excited, and you can't tell the pre-excitation, obviously, if in the first beat or two afterwards you see like this, a longish PR interval, that's very good evidence that the patient does not have an antegrade conducting pathway, does not have Wolff-Parkinson-White syndrome. So now, obviously, this tracing does not in any fashion suggest WPW, but as we all know, people can have intermittent ventricular pre-excitation. And so this is a nice proof that the patient almost certainly does not have WPW. The other thing that's noteworthy is that the patient, you correctly noted all this artifact. Why do you think the patient has all this artifact? What is the patient feeling when they get adenosine?
I guess, I don't know, they're having like this AV bug. They might have just like be feeling like, I don't know,
Relief that
unwell.
they're not in tachycardia?
Maybe, yeah, I
Yeah.
don't know.
Well, the point, I'm sorry, I have a tendency to ask guess what I'm thinking questions, which is totally unfair. But what I'm trying to say is that it's very common. People hate the feeling of adenosine in general. It causes bronchospasm. It causes just a creepy feeling. And if you ask 10 children who've received adenosine, 8 of them are going to tell you that they hated it. I don't know if you remember, Maya, when we were doing an ablation last week, when we gave adenosine during the procedure, we both heard the oxygen sat probe. The sound suggested that there was a slight reduction in oxygen saturation transiently when we gave adenosine. And that's because it causes a little bit of bronchospasm in most patients. So it generally, most patients will tell me, I've never received adenosine myself yet, but people tell me it's a really creepy, warm feeling in your chest. And a lot of times it makes people cough very badly. I suspect that weird feeling was making the patient feel uncomfortable. And this is why you start to see this artifact even before the tachycardia breaks. So presumably the impact is happening already. So if we see a patient with tachycardia at this rate, do you think that this is more likely to be ORT or AVNRT? So now we've seen it in tachycardia. We've seen the termination of the tachycardia. And now we have the 12 lead out of tachycardia in sinus rhythm. So what would you, if you were going to guess, if you were a betting man and we're going to guess what this is, would you think this is more likely AVNRT or ORT? Or is it, Ali suggested it could be atrial flutter, which certainly is possible. It's not out of the realm, but I think the adenosine data, right? The tracing would strongly vote against that, because we don't see normally, right, in atrial flutter, we would see persistence of the atrial arrhythmia, which we don't. The tachycardia broke. So you're thinking more, you mentioned the RP interval. So in this case, we couldn't really see, obviously, a very clear retrograde P wave, right? So that usually is a sign that the RP interval is short or less than 70 milliseconds. So that would suggest what?
AVNRT.
Yeah, that would be more suggestive of AVNRT. What about the heart rate? Does the heart rate give us any insight at all? We said that the heart rate in tachycardia was something on the range of about 170 to 180. Is that a fast SVT for a 17-year-old or a 16-year-old?
No, I'd say it's on the slower side.
It's on the slower side. I agree 100% with that.
I guess, is that more characteristic of an AV-NRT then?
Yeah, generally speaking, and this is not a hard and fast rule, but generally speaking, AVNRT tends to be a little bit slower than ORT. It's not always true, and when you're very young, those distinctions are not as obvious. But this is probably AVNRT based on the heart rate alone. In other words, if somebody just called me on the phone, let's say it's Friday night, it's 11:30, I've done my old man thing and I've been in bed for an hour, and you call me and you say, I'm in the ER and I have a patient with SVT at a rate of 175, and is a teenager, I probably would be thinking in my mind that this is most likely AVNRT, just based on the fact that the heart rate in tachycardia is not especially fast. Yeah, so this is probably AVNRT. And the fact that we don't see any pre-excitation kind of rules out WPW. The fact that we have a short RP interval. Okay, so now you are in the ER and patient is feeling a lot better. This heart rate, which we said was close to around 120, starts to get slower, and patient is feeling well. So it's, I don't know, let's say it's 9 o'clock on Friday night. What do you want to do for this patient? What would your recommendation? Now that the family is like, thank you, Dr. Kalis, you have solved my child's terrible arrhythmia. I'm so happy he's back. What would you recommend I do now for this? I don't want this to happen again.
Probably be started on propranolol.
Well, should be started on a beta blocker usually. Propranolol, right, in a teenager, we don't usually use, right, because it has to be dosed very frequently, and then it does come in an XL form. So some people do use propranolol commonly for older children, but the XL, I think, is a fairly large dose, so we wouldn't normally use that as our first line in a teenaged patient. So what other agents could we consider?
Like atenolol.
Yeah, you could use atenolol. That's a common agent. What's the benefit of atenolol versus some of the other beta blockers? Because you're absolutely right. Atenolol is almost always the choice, at least at our institution, for most of these patients. The reason we use it is it has very few neurological symptoms. It's usually extremely well tolerated. Patients aren't as tired on it. It's also a very weak beta blocker, so tends to have a lot of recurrences. But we would normally want to put somebody on something. So we would typically watch a patient for a couple of hours, maybe put them on atenolol. Another option might be metoprolol. Some people prefer that agent. Some people might use something like nadolol, which is perfectly reasonable as well. You could even put a patient like this on something like verapamil, right? Verapamil is very good with the AV node and is generally well tolerated, not something we use as often, but now that we know the patient doesn't have WPW, we could feel reasonably confident or comfortable to use that. And then long-term, I think, right, we would all agree that probably a patient who has this should consider ablation because this is likely to recur. And, but, as some of you who've gone to clinic with me know, when I see a patient with this type of arrhythmia, I never sell ablation as the only option, because my feeling is that generally speaking, SVT is not life-threatening for most otherwise healthy people. And although I do strongly think that ablation is ultimately the best option for patients like this, I often tell them if they want to take medication, it's not an unreasonable approach. Some people would prefer not to have a procedure and, to see how it goes. So I would not normally admit a patient like this. There are some doctors who do like to admit everybody who comes into the ER with SVT in order to confirm that they stay out of it. And so they'll typically watch them overnight and send them home the next day. There's nothing at all wrong with that. It's just a different style. I think if I have a patient who seems to be very aware of when they're having tachycardia. If it appears to me that the family is keyed into what the issue is and are on the ball, I'll often send them home, but it's certainly never wrong to just admit people and watch them overnight to confirm on telemetry that they've remained in sinus rhythm. Any questions about any of this? No. So a pretty simple case, but a lot of little learning points, I thought. So, all right, I think with that, I'm going to stop for today. I hope everybody has a great week, and thanks for joining today, guys.
Thank you,
Thank
Dr.
you.
Price.
Thank you. Be well.